Hello and welcome to Book Knowledge with Casa Curious. This video is all about infective endocarditis. I will try my best to explain and make this topic easy for you to understand and comprehend. Please note, some of the images used in the presentation are not from Harrison's and I have provided the sources in the reference at the end. I have used them only to illustrate visually what I am talking about. We will be discussing what is this diagnosis, the incidence rate, the causative organisms, in other words, etiology, the pathogenesis, clinical manifestations, meaning how it presents in a patient, the signs and the symptoms, both cardiac and non cardiac, diagnosis, the management and prevention. Introduction. Endocarditis usually refers to infection of the endocardium, that is, infective endocarditis. The term can also include non-infective endocarditis, in which sterile platelet and fibrin thrombi form on cardiac valves and adjacent endocardium. Non-infective endocarditis sometimes leads to infective endocarditis. Both can result in embolization and impaired cardiac function. Prototypic lesion is the vegetation, may be classified according to temporal evolution, site, cause of infection, predisposing risk factors. There are two types: acute, hectically febrile, rapidly damages cardiac structures, may lead to death if untreated. And in subacute, follows indolent course, slowly damages cardiac structures. Incidence. In the developed countries, the incidence of endocarditis ranges from 4 to 7 cases per 100,000 population per year, with higher rates among the elderly. Of the endocarditis cases, the native valve endocarditis accounts for 25 to 35%, which are mostly healthcare workers, while the prosthetic valve endocarditis has 16 to 30% of the incidence, with the greatest stress during the first 6 to 12 months after valve replacement. Etiology. Because of the different portals of entry such as oral cavity, skin, upper respiratory tract, the causative microorganisms vary among clinical types of endocarditis. Streptococcus viridans, Staphylococcus species, and HACEK organisms like Haemophilus species, Aggregatibacter species, Cardiobacterium hominis, Echinella corrodens, and Kingella kingae. These are all involved in native valve endocarditis. Streptococcus galolyticus originates from the gut and is associated with polyps or colon cancer, while the enterococci enters through the genitourinary tract. Prosthetic valve endocarditis, developing within 2 months of surgery, is due to intraoperative contamination or a bacteremic postoperative complications and is typically caused by coagulase negative staphylococcus. Cases beginning more than 1 year after valve surgery are caused by the same organisms that cause community-acquired native valve endocarditis. Endocarditis occurring among IV drug users especially involve the tricuspid valve is commonly caused by Streptococcus. This slide represents the vegetation seen on the mitral valve due to viridian Streptococcus. Mitral valve is the most commonly involved valve due to low pressure compared to the other valves of the heart. Harrison says that HIV infections in injection drug users do not significantly influence the cause of endocarditis. About 5 to 15% of the endocarditis cases are culture negative due to the prior antibiotic exposure. The remainder of culture negative cases represent infection by fastidious organisms such as the nutritionally variant bacteria, Granulicalitella, and Abiotropica species. The HACEK organisms, Coxiella burnetii, Brucella species. Trophairemia causes indolent culture negative afebrile endocarditis. Now that we have learned what are the various organisms and their origin, let us discuss the mechanism of causing the disease. The normal heart is relatively resistant to infection. Bacteria and fungi do not easily adhere to the endothelial surface. Constant blood flow helps prevent them from settling on the endocardial structures. Thus, two factors are generally required for endocarditis. 1. A predisposing abnormality of the endocardium, and number 2. Microorganisms in the bloodstream. Endothelial injury allows direct infection by more virulent pathogen, example, Staph aureus, or the development of a platelet fibrin thrombi. referred to as a non-bacterial thrombotic endocarditis (NBTE) that may become infected during transient bacteremia. NBTE arises from cardiac conditions, example, mitral regurgitations, aortic stenosis, aortic regurgitations, hypercoagulable state giving rise to merantic endocarditis, which consists of uninfected vegetations. After entering the bloodstream, organisms adhere to the endothelium or site of NBTE via surface adhesion molecules. The clinical manifestations of endocarditis arises from the cytokine production, damage to the endocardic structures, embolization of vegetation fragments, hematogenous infection of sites during bacteremia, and tissue injury due to the deposition of immune complexes. Consequences of mechanical injury. Non-bacterial thrombotic endocarditis, in which the bacteria bind to a coagulum and colonize it during transient bacteremia. Adhered monocytes release tissue factor and cytokines. More platelets are activated and the vegetation grows. Endothelial cells are infected and can be lysed by bacterial products, or bacteria can persist inside the cells by changing phenotype into small colony variants. The consequences of inflammatory endothelial lesion. Activated endothelial cells express integrins that promote the local deposition of fibronectin. Bacteria, such as Staphylococcus aureus, adhere to these proteins. Bacteria then are internalized and endothelial cells release tissue factors and cytokines, causing blood clotting and promoting the extension of inflammation and vegetation formation. Finally, infected endothelial cells can be lysed by bacterial products, or bacteria can persist inside the cells by changing phenotype into small colony variants. The clinical manifestations of endocarditis is variable and spans a continuum between acute and subacute presentation. Constitutional symptoms generally non-specific but may include fever, chills, weight loss, myalgia, or arthralgia. Cardiac manifestations. Staphylococcus aureus vegetations are usually more than 10 mm in diameter and involve the mitral valves, whereas in injection drug users it is limited to the tricuspid valve. Heart murmurs, particularly new or worsened regurgitant murmurs, is ultimately heard in 85% of the patients. Congestive heart failure develops in 30 to 40% of patients and is usually due to valvular dysfunction. Extension of infection can result in perivalvular abscess, which in turn may cause intracardiac fistulae. Abscesses may burrow from the aortic root into the ventricular septum and interrupt the conduction system, or may burrow to the epicardium and cause pericarditis. Non-cardiac manifestations. Osler notes tender, raised nodules on the pads of the fingers or toe. Septic embolizations common in Staph aureus endocarditis. Janeway lesions. Non-tender, slightly raised hemorrhages on the palms and sole. Splinter hemorrhages. Linear petechiae in the mid-portion of the nail bed. Rod spots. White, centered retinal hemorrhages. Musculoskeletal pain. Hematogenously seeded focal infections often in the skin, spleen, kidney, skeletal system. Cerebrovascular emboli presenting as strokes. We are more than halfway through the presentation. I hope by now you might have got a clear picture of the disease entity we are discussing. When a patient comes to you with the cardiac or non-cardiac manifestations, you diagnose the case of infective endocarditis based on the Duke's criteria. On your screen, you can see on right hand side is the list of major criteria and on the left side minor criteria. The clinical manifestations and the laboratory workups what we saw so far are classified in one of the two criteria. Now, to make a diagnosis, you need to fulfill either two major criteria or one major plus three minor or five minor criteria. I suggest you pause the video and go through both the tables once to get a hang of it before we continue to the treatment part. Antimicrobial therapy must be bactericidal and prolonged for organism-specific regimes. Blood culture should be repeated until sterile. If patients are febrile for more than 7 days despite appropriate antibiotic therapy, an evaluation for paravalvular or extracardiac abscesses should be performed. Initial therapy before organism identification should be broad-spectrum antibiotics to cover all likely organisms. The following 6 slides are dedicated to organism-specific regime. I won't be reading them to you, so you can pause the video and take note of these. I will play each slide for 10 seconds and then discuss the last part, which is the prevention. The American Heart Association and the European Society of Cardiology have narrowed recommendations for antibiotic prophylaxis, limiting its use to patients at the highest risk of severe morbidity and death from endocarditis. Prophylaxis is recommended only for those dental procedures involving manipulations of gingival tissue or the periapical region of the teeth or perforations of oral mucosa. Prophylaxis is not advisable to patients undergoing GI or genitourinary tract procedures unless the genitourinary tract is infected. This slide lists the high-risk cardiac lesions for which prophylaxis is advised. Thank you for hearing me out and hope I was able to provide you with some knowledge about infective endocarditis. If you find this video informative, give a thumbs up and subscribe. Stay safe and stay healthy.